Witajcie wszyscy jeszcze raz po przerwie. Z nami jest Tim Street, redaktor naczelny serwisu diabetes.com, który Wam opowie przede wszystkim o tym, że technologie, to co mówiłem na pierwszej mojej prezentacji, technologie to nie są tylko CGM-y, to nie są pompy insulinowe, to nie są tylko zamknięte pętle, ale również rozwój technologii pozwala nam rozwijać prędkość działania insulin. I tutaj właśnie o tym głównie, mam nadzieję, powie Wam Tim Street. So Tim, the stage is yours. Have fun.
So what am I going to talk about today? Well, hardware is not the only tech. We've seen a lot today about hardware and software and pumps, CGMs, combining those with algorithms. But if we look back at technology and diabetes, there's a whole lot more to it than that. So first up, who am I? Well, I've got type 1. I've had it for over 30 years. I'm an advocate for and a user of user-led innovation in diabetes technology, things like Android APS, which Miloš was talking about earlier. I write diabetic.com, and I do a whole load of other things. A lot of this stuff I do in my spare time. I have a full-time job. I play sports. I have 5 dogs who are with me in the kitchen at the moment. And diabetes isn't everything that's to do with my life. It's just something that is part of it that I live with and I carry on with. I just have a few disclosures. For organisations that I've spoken for and been paid to speak at their events and who have sponsored me to participate in various conferences. So, diabetes technology has come a long way. Back in 1922, with the discovery of insulin, we had only got syringes. And then we didn't have insulin syringes specifically. We had syringes which had to be boiled, sharpened. That's from Eli Lilly. Looks quite an unpleasant beast, really. And of course, we've now come to pumps, CGMs, automated insulin delivery systems. And all of these are kind of hardware and monitoring tools that we use in order to manage living with our diabetes. But diabetes technology has also gone from insulin that was extracted initially from a dog and then from cows to the newest very fast acting insulins that allow much better management of glucose levels and much more reliable responses in the human body. So what we're going to talk about today is this biotechnology aspect of diabetes technology rather than the hardware and software components that we often do look at. As I say, insulin delivery and glucose monitoring hardware are not the only technology. There's an awful lot more. So if we start with faster acting insulins, here I'm highlighting 2 of the fastest acting injectables that you can actually get your hands on now. Lyumjev, which is starting its rollout globally. Some parts of the globe have it, some don't. It's still quite difficult to get hold of in some parts of Europe, including in some areas of the UK, I'd add. Fiasp has now been around for nearly 4 years, and it was the first of the faster insulins. They typically deliver their capabilities by adding additives to the insulin to increase the rate of absorption. Lyumjev uses something that was used with, I've forgotten the disease, but a pulmonary disease that allows better absorption, causes the blood vessels to widen to get the insulin in where it's injected or where it's used in a pump. Fiasp uses something very similar, nicotinamide. Apparently, according to the patent information, it was discovered by accident that it did the job it did. But there are also other faster-acting insulins. There's Afrezza, for example, which is an inhalable insulin made by mankind. And there's actually quite some special technology in that. The spheres that it's encased in, called technospheres, stop the insulin interacting with the lungs. Some of you may be aware that about 15 years ago, there was a different inhalable insulin, and it had issues with causing lung cancer because the insulin, when it gets into the lungs, is a growth factor, and it caused the lung tissue to start to do things you didn't want it to. And this is what mankind came up with a mechanism to manage that. So inhalable insulin from Afrezza, you breathe it in with your meal, maybe slightly after your meal, because it's that fast acting, and effectively you get no postprandial glucose rises. And these things all make living with type 1 easier. The impact of Lyumjev has shown in a study that the organisation who make it, so Profil, who were sponsored by Lilly, who make it, undertook. And the two graphs you're looking at here show, on the left, the mean glucose rise and then drop after a standardized test meal. And then on the right, comparing early, which is Lyumjev, with Humalog and with healthy subjects. What's quite interesting on the first of the two graphs is that the early, or Lyumjev, significantly outperforms both Fiasp, Humalog, and Novorapid. You can see that the average rise postprandially is significantly lower. What was perhaps more interesting is, if you look on the second graph, was that the Lyumjev appears to be generating results that are almost in line with healthy subjects postprandial glucose rises after eating, and actually at 2 to 3 hours seems to be slightly worse, but that could be handled by potentially another jab at that point. These faster acting insulins obviously make postprandial glucose rises much less strong, and that means that after meals your glucose levels stay lower, so you have less hypoglycemia, and ultimately your long-term time in range is improved. It also presents opportunities as to what you can do with your insulins in the closed-loop systems that we've talked about earlier with Milos, and it presents some very interesting opportunities, but we'll talk about that later. Also on the biotech side, we have the longer acting and we have smart insulins. Now, that first image talks about insulin icodec. Icodec is a novel insulin from Novo that can be taken once a week and acts as a long-term background insulin compared to Lantus and Toujeo, which require daily injections. Now, this is aimed primarily at type 2s, but potentially if you are a not particularly active type 1, there may be opportunities for icodec in type 1s, but it's not really been investigated yet. It just raises some interesting ideas. The second on this slide is the glucose reactive insulin, or glucose reactive system. This model shows two things really. If we look at the first circle here, what we're talking about is a excuse me a second. What we're talking about here is a shell that is glucose reactive, and as glucose levels increase, so the insulin is released from within the cell. Now, that could be applied as a patch that was sitting with microneedles that just sit on your skin and replaced daily. It could be an injectable insulin that sits within the body and is injected once a day, maybe once a week, maybe even once a month. Novo have been doing, or bought out recently, a company that has been looking at how it can do this, and apparently are starting to look at introducing human trials for this type of insulin technology. One thing to think about here is the insulin, or the substance being used, is reacting with the glucose in the body in order to release insulin. So in many ways, isn't that an artificial pancreas, just being delivered purely in a biological form rather than using anything that's hardware and software that you can see that sits on your body? It raises some very interesting questions in the longer term as to whether you will actually need a CGM or a pump or even an external algorithm in order to have your diabetes managed for you. In the meantime, there are also adjunct therapies, things like SGLT2 inhibitors. These reduce the glucose absorption in the kidneys by blocking the sodium glucose transporters that take the glucose out of the kidney tubules and bring it back into the blood. So what you're basically doing is urinating the glucose out rather than having it reabsorbed in the body. It's been used with type 2s for a long time. It also helps lose weight. I know a few people who are on these as an adjunct therapy alongside their standard insulin therapies. They do come with an elevated risk of euglycemic DKA, diabetic ketoacidosis, because of the way that they fundamentally work. And so anybody using them requires, I guess the best way of describing it is additional oversight of what they're doing and making sure that their ketone levels remain within a normal zone due to the risk of ketoacidosis alongside the use of these things. Well, it's worth pointing out that it's not a huge increase, but you do see it. People I know who have used these say they found it quite interesting because once you get above the point at which glucose is excreted in the urine, you kind of no longer have particularly high highs. So you are able to maintain a better time in range purely because the glucose is getting kicked out of your body and you don't ever get to those high levels. Additionally, we have things like Symlin. Now, what is Symlin? Symlin is synthetic amylin, which is where the name comes from. It's called premlinitide. And what it does, well, as a person with diabetes, with the loss of your beta cells, you also lose the production of amylin. And what amylin does in the body normally is it suppresses glucagon release, it slows the rate of food moving from the stomach into the small intestine, and it has an effect on the brain to make you feel fuller. Symlin replicates this and is something that can be taken alongside insulin in order to manage glucose levels post-eating. As far as I'm aware, it's only ever been authorized in the US. I've never seen it available in Europe. But as an adjunct therapy, it makes for some interesting ideas as to what you can do alongside insulin in order to better manage the body's reaction to eating. Because one of the things the body does is when you eat certain foods, it will release glucagon with the expectation the body will release insulin so that it gets enough insulin to act on the foods, especially when it's related to certain types of protein, but you never actually have that insulin there. You're doing it manually, so the glucose release takes place anyway, and you don't know about it as much. Alongside Symlin, we've just mentioned glucagon. Now, we still produce glucagon as people with type 1, but historically, the only glucagon externally we could get was that powdered form, which you had to mix with liquid, and it lasted less than a day. It was use once or use only in the day and get rid of it. We now have forms of glucagon that can be sprayed up the nose, Baqsimi, or the Gvoke HypoPen, which is a form that's stable and lasts for much longer than a day. I think there's another one, Dazai glucagon. Now, why is this important? Well, both of these things can be used alongside insulin in order to manage glucose levels. So you potentially, rather than take glucose when you're doing sport, when you start to approach a hypo, you might do a micro glucagon shot. Now, there are some limitations relating to that, and that is the more times you use glucagon, the more the glycogen in your liver becomes depleted until you get to a point where there isn't enough glycogen to be released, to be converted to glucose and released into your bloodstream. So you do have to manage some of this stuff, but it does broaden the set of opportunities we can do, of things we can do with the technologies available, and also it broadens what we can do from an artificial pancreas perspective. Why do I say that? Well, at ATTD and the ASD last year, there was a presentation on an artificial pancreas system that used premlinitide, Symlin, what we were just discussing, alongside rapid-acting insulin to see what the results were. And that image on the left is really quite interesting, because what it shows us is that by combining rapid insulin and pramlintide, the postprandial glycemic excursions of users on 56 grams of carb food were pretty much minimal. While rapid insulin on its own, you can see there's a very clear excursion following that dose. What we also see is that the number of units of insulin required is lower with the insulin and pramlintide. So it raises some interesting questions about what the best approach is to deliver insulin and what the best approach is to manage diabetes in terms of multi-factors rather than insulin alone. Secondly, on the right-hand side there, you have an image of the Beta Bionics islet artificial pancreas, which uses both glucagon and rapid-acting insulin. So it adjusts both of those things to try and maintain glucose levels. I haven't got any of the results from that, but most of the results that have been published have been shown to be relatively promising. So both of these are slightly different approaches to delivering actually an artificial pancreas system, and that uses, in both cases, more than one biotechnology. They approach things slightly differently, but without those underlying components, the hardware and software sitting over the top of it would be irrelevant. And that's why they're important. And finally, in terms of artificial pancreases, we also have the islet encapsulation that a number of companies have been working on for some time. This shows a list of specifically one manufacturer's encapsulation technologies. And what they do is they take islet cells, they encapsulate them in effectively a pouch that sits within the human body, and then within that pouch, the islet cells produce insulin, and what you're trying to do is to protect those islet cells from the autoimmune attack, and at the same time have something there that will produce insulin, takes away the need for glucose monitoring and for insulin injections or insulin infusion, and hopefully, if you can make it work properly, doesn't require you to do a huge amount of number of replacements. This stuff is also going through clinical trials at the moment in the US, and again, many of these systems seem to be quite effective. What's really interesting is that one in the middle there, which doesn't require long-term immunosuppression. So it means you don't have to take long-term immunosuppressive drugs that you would have to take if you had a pancreas transplant, which obviously is much more challenging. So islet encapsulation is also a very interesting area of biotechnology as an approach to delivering more effective and safe solutions to living with type 1 diabetes whilst we don't have a cure for this condition. But the most important thing to take away from all of this is that while CGM pumps and automated insulin delivery systems are very visible technologies, they're not the only thing that people are working on. The hardware is a solution to a problem, and there are alternative ways of dealing with those problems. They're a little bit more tricky. They require potentially much more research. And obviously, any of these things has to go through clinical trial stages. It has to be made available. Right now, the faster insulins are the best thing that we have. And by adding those into the algorithms that we have available for things like Android APS, we're able to start seeing results where it's possible to never announce any meals that you eat, to not give any pre-meal boluses, to just let the algorithm run and get a time in range of 90 to 95% with minimal hypoglycemia. That's being done by a few people who are working on very, very experimental code to see how it works. But that's really exciting from a diabetes management perspective. Once we start to add in some of these other tools in the toolbox, some of these things like glucagon or like pramlintide, potentially that becomes easier and potentially much safer, because one of the key issues with insulin only is that you do have a hypoglycemia risk, which you have to manage. If you have something that allows you to arrest the onset of hypoglycemia, then you're in a very good position. But the key point to take away from this is that artificial pancreases are not only pumps and CGMs. Artificial pancreases will also include smart insulins, glucose-responsive insulins, that no longer require something visible to sit on the outside of the body. They will give you something that you are able to hide inside your body, maybe once a day, maybe once a week, who knows, maybe even once a month, that will continue to operate whilst you live your life and hopefully won't do things that are stupid, unlike maybe we do manually ourselves. And finally, there's this encapsulation technology that's at a very early stage. But if it works, can you imagine having an annual or maybe a 5-yearly outpatients operation where they swap an old pouch for a new pouch, and that's it? That just gets on with it. It's always interesting to find out what people think of these different things. Would you want a device like that embedded in your body? Would you prefer a smart insulin, or are you happy with a pump and the level of control that a pump with an AID algorithm on it gives you? What it opens up is a wide range of choices for individuals as to how they will get their diabetes managed and how they will get their diabetes treated. And it raises questions for healthcare providers as well as to what they should recommend and why they should recommend it. But it certainly gives us a future that looks like it's going to be a lot easier to manage our type 1 and to get that magic time in range number to be at a level where you can't distinguish it from somebody without type 1. Thank you very much for inviting me to speak. I'm now going to stop sharing the screen. And we should now be able to go back to Jerry.
Yep, I'm here. Thanks, team. I'm actually mind blown if it comes to new technologies and the things you've just shown. I wasn't even aware about most of them. A little about Afreeza. I've heard about this inhaled insulin, but here in Poland we didn't have. I don't think we have even an opportunity to test it.
No, so, you have to buy it from the US if you want it. It's not actually licensed in Europe at the moment. Oh. But at ATTD last year, the Mankind representatives there who presented on it said that they were looking to get EMA approval. They said in the next year, but I think COVID's put a bit of a stop to that.
Cool. I think people are just so overwhelmed by the things just shown that they don't have any questions, as far as I can see on the chat. So one question from me, team. Do you think in a near future, will there be a cure for diabetes if it comes to, some kind of a pill, or the all things that we should look for in the future is technology?
There have been discussions about pills, and the challenge is the challenge with a pill is getting it through your alimentary canal without the insulin being destroyed. That's always been the biggest challenge. There have been recently some news stories about somebody being able to do that. It's almost the same challenge that you have with smart insulins, actually, which is that how do you get it through, be assured that it's being delivered and that it's doing the right thing? And that's always going to be the challenge with a pill-based approach, which is why something like Afreeza, for example, is probably more reliable. And that's ultimately what sort of the biotechnology approaches have to try and figure out, is how do you make it a reliable delivery system so that you can consistently deliver the same amount of insulin every time you eat a meal, for example. That's really the challenge with this type of thing. I think some of the smart insulin technology potentially removes the need for what we consider classically as diabetes technology. So I think that looks very promising. But let's be honest about that. It's not even at phase 2 clinical trials in humans yet. So you're probably looking 5 years. One of the key issues that the product, I think it's called Xylo, which is the one that Novo bought, they'd done some sort of phase 1 trials with it and discovered that they were struggling with a high risk of hypoglycemia. And one of the benefits of Novo buying them was that they thought it would help to get over that problem. So it's a watch this space, but in the short term, the technologies that we have available are pumps, AID algorithms, CGMs, and they will improve the ability to manage diabetes for many people in the short term before we get on to some of these newer, more novel solutions.
Cyberpunk solutions. A little. Last question, Tim. As far as I know, and as far as I read your Diabetes.com blog, you did test Lyumjev with a UAM algorithm on Android APS. Can you tell a few words about it?
So Lyumjev, firstly with Lyumjev, it took me a while to become acclimatized to it. So when I first used Lyumjev with the pump, it didn't work properly. It was taking a very long time to not actually deliver enough, to not actually affect my glucose levels. I ended up having to mix it with Fiasp initially, and then after a while, my body got more used to the additive in it, and then I was able to switch over to 100% Lyumjev. With standard Android APS, it's pretty good or standard OREF1 is probably the better way to describe it, which is the algorithm in Android APS. It works. It does give you a better time in range. The faster insulins compared to using something like Humalog or Novo Rapid, in my experimentation, gave around about 5 percentage points more time in range than the older slow fast-acting insulins. But there are certain things that you can't do with the faster-acting insulins with the standard algorithm. The most important one of that being, the reality is the way glucose is absorbed by the body is that you end up with a curve that sort of goes like that. And because it goes like that, if you don't take any preemptive action or action when you start eating, you've already jumped 20 to 40 to 50 milligram per deciliter before really the algorithm is kicking in and doing anything. So there's been a lot of stuff going on with people experimenting with how you might predict that or how you might get something ahead of that, so that you can get a larger dose of insulin early enough in that cycle in order to get a better outcome. I've been playing with some stuff. I know a bunch of other people have been playing with some stuff. As I said, it's all very experimental, but it does seem to have a reasonably good effect. The challenge with it isn't writing code that works for you. It's writing something that could then be tested properly and scaled for every user such that it didn't increase risk of hypoglycemia, didn't increase risk of overdosing insulin, and allowed them to be safe and effective in its use. And that's really the challenge with trying to do these types of things.
Yeah, if you look on the history of diabetes technologies, you can see that there was a huge step last 20 years. So I think that if you look for the future, 5 years is like not that big a deal to wait this 5 years, and even on 10 years. You know, when I was diagnosed in 1995, the doctor said, just you have to live for like 10 years and there's going to be a cure in 10 years. After 10 years, I heard the same thing. There's going to be a cure in 10 years. And now we're hearing the same thing. So it always goes forward.
I mean, it's interesting because it's in that same area. What is a cure? Yep. Type 1 diabetes is two things. It's an autoimmune attack on the body, on the pancreas, and then the symptoms of that autoimmune attack are no islet cells and therefore, or no beta cells, and therefore no insulin being produced. So a cure is two things. It's being able to regenerate or replace beta cells, and it's also being able to stop that autoimmune attack on the body. And there's been some interesting research going on in order to try and do the first of those two things, which is to retrain the body's autoimmune system so it doesn't attack the beta cells. And some of the research in that has had its very early stage clinical trials again, but it's got one or two people being given who have got the obvious indicators of potential on type 1 coming up, who have been given I don't want to use the word vaccine, but have been given a solution that stops the body attacking the beta cells. And it's apparently looking very promising. It's been published in some of the literature available. So if they figured that bit out, which is to stop the autoimmune attack, and they can figure out how to regenerate or replace beta cells, and then you've got a solution.
Okay, actually the thing you are talking about is a TERG, TERG solution. How do you call it? It's happening in Poland, in Gdańsk, actually. The studies there, and it looks promising, but still, I think it's kind of a short period of time to have any results.
Absolutely, I mean, I agree completely. It's interesting. Somebody's commented in the chat about an absolute cure would kill the pharma business, no chance. I think people overestimate the actual value of the type 1 business to pharma. The reality is that we are 10% of the treatments for diabetes. The real business is in type 2, and fixing type 1 doesn't remove 90% of the pharma business for diabetes. So if you fix type 1, the reality is they see very little difference in their revenues because they're selling all of the type 2 products, which are a much broader range and have a much greater reach. So actually, I'm not as suspicious of fixing type 1 would stop the farm, wouldn't happen because the pharma business wouldn't make any money. They don't make money from us. We see that massively from Johnson & Johnson pulling their Animas pump solutions. We see it from the pull-out of Roche from the US market. We see it from the likes of the fact that rapid-acting insulins, the biosimilars for rapid-acting insulins, generally don't go on the market as significantly cheaper than the standard versions of them because you still need to make money from them to be able to produce them, and there aren't enough people using them to make tons of money out of them. So I think we should be a little bit less cynical about cures for type 1 because the reality is that's not where the money comes from in diabetes.
Sure. Thanks, Tim. The time is short, so we have to end now. But I'm gonna send you a few. I see some questions appeared here, so I'm gonna send you an email. And if you want to, if you can, just respond to me, and I'm gonna publish them somewhere on my website or something like that. So thank you again. Thanks for your time, for your speech. It was really mind-blowing. I'm looking forward for all of the technologies that are showing up on all around the world, hopefully here in Poland and before in Poland, in Europe. And have a great day.
Thank you very much.
Thanks.